Well, it's really fun to be here among friends. I think I know most of you, maybe a couple know, not yet. But as Jessica mentioned, I've been collaborating with Jean Johnson and now with Chung Young and with Ellen Kurtzman over the years. So my work has been very close to this school. So this study in particular was the product of a grant from Robert Wood Johnson Foundation. I had worked for several years with Sue Hassmiller at the foundation to coordinate the research that went into the IOM report on the future of nursing. And after the publication of that report, we did a series of projects that were related to evaluation of the implementation of the recommendation. So to some extent, the framing of the research question was, will the IOM's prediction that health reform, and in particular payment reforms, have a big impact on the way nurses are deployed in our healthcare system? And so this was an exploratory study. Nobody had looked at whether, in fact, there are changes in the way nurses are being used in particular pioneer ACOs in this study. Although there had been a lot of speculation in the literature that there would be new roles, and in particular that nurses would be used to sort of in a fuller capacity than they had been in previous decades. So this, it's a qualitative exploratory study, but I think it opens up some avenues for future research that is more quantitative or at least mixed methods. So I will get started here. There we go. So I think, as I said, the sort of theoretical question is, as you move from a fee-for-service kind of payment system to a more outcomes-based payment system, will you see changes in the way the workforce is configured, first, and secondly, more specifically, will you see changes in the way nurses are used? There have been very few studies on this question related to the workforce more generally, and even fewer, 0 to 0, on nursing. But there was one study that I have found incredibly provocative and interesting that was done in the UK. And they looked at how the pay-for-performance program in England in particular in primary care affected the use of nurses. And the background to that study was sort of interesting because for years the central government the central governance of the national health system had been trying to promote greater use of nurses in primary care in England. And they were offering money to pay them. They were offering money to expand the clinics because the physicians said, well, we don't hire them because our clinics aren't large enough. And nothing seemed to work. Physicians were not interested in hiring nurses for primary care. Well, along came the pay-for-performance innovation, and there was a longitudinal study that looked, among other things, at how the primary care trusts were configured and what the practice teams looked like. And sure enough, when you had a reward for certain performance measures, suddenly you had sort of massive hiring of nurses, and you had a shifting of tasks from physicians to nurses. So the number of physician visits declined, and the number of nurses employed in these settings increased, and the kinds of roles that they were playing changed dramatically. So while the study obviously has nothing to do with the United States and ACOs, we do see that money matters in terms of hiring practices, at least when physicians are in the driving seat. I looked, that all of you, I'm sure at this point, understand the ACO phenomenon, the accountable care organizations. I won't go into the 101 of what that is. But there are 3 or 4 different kinds of programs that CMS has, and the pioneer ACOs are kind of the most advanced, if you will, ACOs. They were the first to come out. There are 32 of them. They were the organizations that had some experience either in Medicare Advantage, which is a capitated system, or some form of managed care with Medicaid systems. So they were both experienced and more willing to take a higher risk in terms of the shared savings than the other programs that came behind. So there's sort of an interesting group, both because there's so few of them. There were 32 at the time that we began the study. There are now 19 because a number have dropped out. But they are, at least theoretically, sort of leaders in terms of adjusting the delivery system to these new payments that are outcome-based. So if we were to see changes anywhere, it's one could hypothesize that you'd see them first in the pioneer ACOs. So that was our universe, if you will. So I talked a little about the UK study. The two other bodies of research I think that are important, or really three actually, that I should mention. One is that there had been a fair amount of literature leading up to the IOM report about the fact that population-based care and was going to require a new role for nurses, and so there is that opinion-based literature, if you will, anticipating that there were going to be changes. We also have a lot of research on very specific kinds of nurse-led models. So, you know, the Mary Naylor model, the Chad Bolt model, the care transitions of all different kinds, and there's a fair amount of research that shows that these are cost-effective models. So that's pretty well documented. But on the other hand, we had a series of studies coming out showing that medical assistants are being used more and more in primary care in particular, and obviously they're less costly than nurses, and so there's been sort of a trend in the opposite direction of using nurses in primary care at the same time. So those studies had occurred in settings where you didn't have outcome payment changes. So if the trend sort of historically had been moving towards MAs in primary care and away from RNs, if we were to find anything in the ACO setting, it would be particularly interesting and would suggest that probably the payment is what's driving it. So our methods, we are asking essentially whether the role of RNs have changed or not, and if so, how. In the absence of a baseline, we are doing a qualitative exploratory study. We interviewed leaders in 18 of the then 32 ACOs, and I'll skip right to the epilogue, which is that 3 of our sample actually were dropouts. However, all of the dropouts went to the next level down of the ACO, so they continue to be ACOs, they're just not pioneer ACOs. And we have a pretty good spread by size, location ownership, and whether or not they were an HMO before they started in our sample as compared to the universe of 32. So we're pretty confident that we have a good sampling within this very small universe of the 32. We interviewed chief nurse officers for the most part, but where there were no chief nurse officers, we interviewed 1 chief medical officer and 1 director of innovation population health, which were the positions that were closest to what the leadership thought would be a CNO kind of a role. We did semi-structured interviews where we looked at the history of the ACO, how they were using RNs before entering the program, the new roles and their deployment since the beginning of the program, and their challenges and plans going forward. We taped and transcribed them and did a narrative analysis. In terms of a conceptual framework, some of you may be familiar with Bonnie Sibolt's task shifting framework. This is sort of an adaptation of her work. I think it begins to give us some language about how changes in the deployment of the workforce can be conceptualized. These are 8 categories: enhancement of a particular role with new activities, the substitution of one profession for another, the delegation of tasks to a different worker. This could either be within a profession, for example, within physicians, it could be from a specialist to a primary care physician. The addition of new types of workers, changes in the numbers of workers, the transfer of services from one setting to another, which is often forgotten about when we think about workforce changes, the relocation of the workers themselves from one venue to another, and the use of liaison consultants, as they would call them in the UK, across settings, which is an interesting new function. So this is sort of the terminology that we used as we went through and tried to classify the kinds of changes that were occurring. So overall, just a sort of quick snapshot of the findings. Essentially, all ACOs that we interviewed said that they were changing the way they were deploying nurses. So it was 100% absolutely convinced that it was essential to change the way nurses were working. And they were all talking about hiring more nurses. So while we don't have the hard numbers, this is obviously important in terms of workforce planning. The demand for nurses is going to go up to the extent that there's a transformation of payment methods. The kinds of things that we saw were use of liaison, the substitution, the delegation, some relocation. All of these things were common but not universal. And most of the changes that we saw were in primary care. So as you know, the ACO encompasses the full continuum of care. Most of the changes were in primary care, but we also saw some changes in hospitals, in home care, and in nursing facilities. And there were lots of concerns about difficulties implementing these changes. So those are quite interesting in and of themselves. Okay, so going right into sort of what they said and what their rationale for change was, I think there were sort of 4 ways of talking about why they needed to change and why they needed to change nurses in particular. And they're very overlapping, and they use this terminology in a very similar way. But basically the idea of shifting away from a volume approach, keeping patients at the lowest possible point of care, focusing more on patient engagement, and moving to population health. And these ideas kind of circulate in their discourse in different ways. This particular text is sort of interesting because it combines all of them in one. The focus is on keeping the patient at the lowest possible point of care, whether it's home with nothing, at home with home care, et cetera. And as complexity or need increases, we ask, what's the next level of caregivers that it's appropriate within that context? That's why we're really starting to look at different roles. I think we're just at the beginning of this process of using RNs in new ways. Another response that was also sort of, extremely explicit in his explanation was, we're trying to keep patients away from doctors and hospitals. That's essentially our new mandate. So I'm going to run through each of these settings: primary care, hospitals, and home care, and nursing facilities. As I said, primary care was sort of the 800-pound gorilla in terms of where the changes are. So in particular on sort of why the change in primary care is important, these are some of the views. So before we started this journey, we didn't have nurses at all in primary care. We had LPNs or MAs. Moving away from the old model of relying exclusively on MAs, we're moving into a time when almost all practices will have a nurse. As part of moving from physician-centric to patient-centric care, everyone had to have a new role. We expanded the role of the RN. We were using them in passive roles in the past. For example, answering phones, taking blood pressure, accompanying patients to doctors' offices. And now they're going into more active functions. We carved out a function for the RN as a leader of the clinical team. This would be sort of an enhancement kind of a change. And then a relocation change, and that's when we stole some of our inpatient care nurses. Their skill is assessment, evaluation, triaging, and care management. They wanted that in primary care. So I've tried to create sort of a typology of these new roles. All of this is very debatable. I've used the terminology that they use, but of course not everyone uses the same terminology. So to some extent there's some arbitrariness in deciding what to call each of these things. So in particular, this first one is debatable. I'd love your feedback. But what a lot of people call these nurses that were in their more active as opposed to a more passive function in primary care were embedded nurses. So 17 of the 18 ACOs use RNs in this function as embedded nurses now. What does that mean? It means an enhanced triage role, follow-up with patients, screening and medication adjustments, and then in addition, RNs may be overseeing LPNs, MAs, and community health workers. They're interacting with the hospital-based transitionalists, and they're providing health education services to community leaders and patients outside the clinic setting. So these are probably roles that are familiar to some of you, particularly those of you who've worked in nurse-led clinics, but they're not the traditional role for nurses in primary care. So that's sort of the first, a more activated role within primary care. The second role is really quite different. It's actually nurses providing direct care. So this was not universal. 3 of the 18 were using nurses for generally what they described quick acute conditions. So UTIs, vaginitis, hypertension management, asthma care, titrating of medications, pediatric development checks, bone marrow transplantation, solid organ transplant, diabetes, hematology, oncology, et cetera. And 2 of those ACOs actually had freestanding clinics that were led by nurses by themselves that did very specific, very narrowly defined, sort of protocol-driven kinds of functions, anticoagulation and pulmonary hypertension. So standalone nurse clinics for that function. So that's the second role that they described as as new for nurses in primary care. And then the third, which is not new because many of them had care coordination before, but is radically expanding, is care coordination. So this was 18 of the 18 ACOs were doing more care coordination than they had before. As we moved to care management, it had to be done by the RN. There was no question. So system-wide, we now have over 30 care managers. So this is sort of the new care management. The more people, the care manager piece is definitely growing. We're building up a number of professional nurses who can work with those patients. There's also some care coordination happening at the ACO level, right? So there could be an office that coordinates all the different component parts of the ACO, and that is essentially a liaison kind of function. So they had some people were stationed at that central level while others were in clinics. And then the ratios were, just hysterically different. I mean, there just was like no sense at all that I could make of it. It really depended on, some of these were disease specific, some of them were population specific. So they're really, and it would take definitely another study to begin to drill down and understand how they're starting to do staffing calculations based on the need for care coordinators. It's really pretty complex, and each organization does it in its own way. So the additional settings in hospitals, I think there were really two important kinds of roles that are new. The first was an enhancement of the traditional transitionalist. So before, the case managers focused on admissions, on the RAC and discharge planning. Now they assess patients, meet with the hospitalist team, apply a risk stratification tool, often supervising lay workers who are actually managing the databases, and they start the care transition process. There's hiring of more nurses to do this kind of work as well. So again, it's going from a more passive kind of function to a more integrated, active function. And the other thing that was not universal, in fact, this was only in one ACO, but seemed really significant to me, was telemedicine. So because of all of the regulatory barriers having to do with physicians doing telemedicine, they had their nurses doing telemedicine instead. They had less regulatory oversight. So they had nurses in ICUs in cities providing support to physicians and to nurses in their critical access hospitals. This particular ACO is in Arizona, obviously a more rural-oriented area, but they saw that as an expanded area of work for nurses. In terms of home and hospice care, there were teams, and this is something that I think we heard pretty universally in general. The ACO leadership feels that the weakest part of the continuum of care and where there's the most waste and where they have the most potential for shared savings is the home care, long-term care, sort of post-acute section. It's just a really immature industry that hasn't grown up yet. They think that they need to bring to bear their management skills on that sector. So the first thing they're doing is, of course, putting together teams of people who go to homes, usually led by NPs, but often including RNs as well. It may include a pharmacist or a social worker. And a lot of that work is actually coordinating with the skilled nursing facilities. So it's also they visit the skilled nursing facilities and they visit the home. They're going back and forth. So that was viewed as an important and expanded role. So this is sort of an attempt at a summary here, just in case you all see any patterns that I haven't seen. So if you think about primary care, hospitals, home, and liaison with skilled nursing facilities, B is when they're based in a certain place, and C is when they coordinate across settings, which in the Cebalt language be liaison. And I've sort of emphasized the terminology that relates to the Cebalt framework. And I mean, I guess at first glance, one thing is most of the changes are happening in primary care. Another thing is that at least half of the changes have to do with care coordination across settings. So although people may be based in a setting, they're probably at least half of these things are happening across settings. Love to get your feedback on other things that you all see happening in here and how you would kind of describe the phenomenon as a whole. I think it's still lots to be squeezed out of this. In terms of the difficulties of implementing these roles, I asked them what kinds of problems they were facing, if any, in making these changes. So there are a whole lot, and I'm going to skip actually to one that in the future iteration I'll put first, because I actually thought it was the most interesting, which is that most of the ACOs, The nursing leadership role was hospital-based. So there's a chief nurse officer in the hospital, but on the primary care side and on the home care side, there is no nursing leadership. And so the CNO was recognizing the need to sort of renovate nursing services across the whole ACO, but she had no one with whom to interact in other settings. And so there was sort of a call for having an equivalent in the non-hospital setting that could help coordinate and help, supervise, and do training programs and all the things that executives do on the non-hospital side. So that was, I think, something that they are bringing to their boards and beginning to work on. An interesting thing that was particular to those ACOs that had been HMOs before was a cultural shift for the nurses. So they described a lot of the nurses as having been very authoritarian in the way that they interacted with patients in terms of expectations of change, and now that they had choice in the context of an ACO, which they don't have when they're in an HMO, there's a big change in terms of how you interact with patients, and that was not an easy transition. That's part of what they're working on, to going to a sort of a more patient-centered, lead from behind kind of a model, as opposed to a tell you what to do model. On the management side, there was talk of what one participant called an embarrassment of riches in terms of care coordination programs that were bumping up against each other and duplicating and creating a lot of confusion for physicians and a lot of confusion for patients. There were just too many good programs that were, and they recognized that they were going to need to sort of start systematizing and simplifying these roles. The roles were not yet clear to patients and to physicians. A lot of problems in terms of interoperability of the EHRs across the sites in EHRs, and that was particularly problematic for nurses who were doing the care coordination. Complaints about the inability to charge for direct services that nurses provide, in the case of Medicare. And then complaints about educational institutions, that schools of nursing are not preparing nurses for population health. We need new residency programs for nurses in population health. And we need help with this now, yesterday. So those are sort of their list of problems that they would like all of us to work on. The epilogue, as I mentioned before, is that 3 of these organizations moved one step down in the ACO. Interestingly, we went back afterwards to see if there was any notable difference between the 2 groups, and there was not. Just a little sidebar on what I heard when I was talking to them that might suggest that they were going to be dropping out. In particular, those ACOs that had a big hospital system within it were facing a lot of complaints from the hospitals that their revenues were going way down because programs were working too well. And that hadn't been calculated in the shared savings. They just hadn't planned for that to the extent that it was happening. So that's interesting. I don't have a representative sample, but that was certainly interesting that they were saying that. So generally, this conclusions, change is afoot. There's chaos in terms of the terminology of what this change, how to talk about it and how to describe it. But the pioneer ACOs themselves describe the reason for the heightened attention to nurses having to do with transitions and gaps across settings. So that seems to be really where nursing is stepping up. So in terms of what we don't know, based on this study, we certainly don't know whether all kinds of other changes that are happening in the environment are also making this more likely to happen. There are other kinds of payment incentive programs that are happening at the same time. So, the hospital readmissions penalties, the never events, all these things are also obviously having an effect. And how that accumulation of incentives is working, we don't know. We also know that hospitals are feeling the squeeze now. Although now with expanded coverage, at least in states that have expanded coverage, perhaps that squeeze will be lightened. But in general, one might hypothesize that where you have squeezes and people are tightening their belts, you might have to have shifting downwards where nurses might have an enhanced role. On the other hand, when we had belt tightening in the early 90s, nurses were fired. So, but it's worth thinking about going forward about how that is playing out in terms of the changing role of nurses. I also think that while there's effectiveness research on specific nurse-led innovations, we don't know in a business sense what the ROI of how those innovations get integrated. And I think that will be playing out at the business level and is an area for researchers to be watching as well, because it's very different from an RCT when you're looking at the effectiveness of these kinds of innovations. So, they're paying for a lot of these new roles out of their pocket. They're not being reimbursed for them. So the ROI really matters, and they're going to be doing those calculations. So I think that's sort of the next chapter to be watched. So I would absolutely welcome your reactions and feedback. One of the nice things about this audience is that you guys know the topic better than I do. So I'd be, lived it, or are living it. I just heard, I was telling John Young today that our own GWMFA is starting an ACO. I didn't realize that. So it'll be, not, the hospital's not part of it. So it'll be interesting. We can watch this phenomenon right down the road and see how that's changing. The first thing he said in his brown bag lunch was, I'm looking for nurse navigators. You guys know any? So he doesn't seem to see this as a sort of broader phenomenon. It's very much like a hiring, an HR issue, as opposed to a systems change issue. But I think it's, people they're beginning to see it more as a systems issue. Yeah, so love to hear from you guys.
So I happen to have been working with one of these pioneer ACOs that did use nurses in direct care, but because of the payment issues with Medicare, decided they could no longer do so. And so it seems like it's a really big challenge, and I wonder how much trying different approaches and sort of, like, I wonder what the story will be in another year or two as they're sort of finding what works, both logistically and.
I mean, most change is 2 steps forward, 1 back, and then 2 more, and there's going to be one would think that Medicare, since they're doing an evaluation of the pioneer ACOs, would be hearing the same thing that I heard, and that the innovations office would be talking to the payment office and saying, we probably should be reimbursing for nurse care, at least for ACOs.
It wasn't just the
historically, though. I mean, nurses have always been part of the room charge in terms of hospitals and so forth. And instead of being able to receive reimbursement for services rendered. And so much of what happens in nursing is cost savings related to efficiencies, like you're talking about, like people not bouncing back into the hospital again in terms of readmissions. There's a cost savings there. But who measures that? Where is it captured? Is it captured on the hospital side? Who's paying for the nurse? Is it the hospital, or is it the ACO on the outside of the hospital, or the physician's office that's paying the nurse? So if the nurse is being paid over here, but the benefits being reaped over here, there's a disconnect in all of that. Yeah. And so we have to find ways of somehow capturing that, or beginning to look at, and nobody wants to look at reimbursing anybody else in the players group, because everybody looks at that as being more money. But if you feel that nurses are helping to prevent readmissions, complications, et cetera, then that pay for performance shouldn't be going to the doctors or the hospitals. It needs to be spread to justify the nursing positions, because they're the people that are changing the care.
Right.
But I like with your categories, I can't remember them all right now, but you were talking about substitution. When a nurse is being used to substitute for a role that was billable. I mean,
that would be similar to an NP kind of a function. Right. So I've been hearing that more and more private commercial carriers are reimbursing, and I wonder, because they see the economics, and I wonder if it's just a matter of time before Medicare will too. I mean, it just seems so obvious. It's
And you're talking about for RNs.
For RNs, I mean,
so how do I know this is really a big push by RW, the Reverend Johnson Foundation. I chair the expert panel in primary care for the Academy of Nursing, and we're taking this on. RN in primary care, Ellen Marie Whalen has been part of the leadership in that. She's one of the RWJ fellows, and they've just done a paper on this
Yeah.
issue, or maybe you've seen the
Yeah.
paper. And so I know this is a very big push, and there's going to be, I know from the academy, there's going to be a big push to push this out. And some of this came from, and you met the ABIM, the Association for Board of Internal Medicine, and there are these, we call them the this joy article that doctors are getting, physicians, not in ACOs, but in primary care, having great joy in their practice when RNs come in and do things for them. And it's, it kind of really grates at us a little because, sometimes they're scripting, sometimes they're scribing, things like that. Sometimes they're doing much higher level things, And my question is, and this is not totally related to the ACO, but maybe it is, that I think RNs are going to be more parts of teams, not just helping physicians, but helping NPs in practice, who really are dying. All of them in primary care are dying because they're doing so many things that really they don't have to do, and that RNs could really help them to be more efficient, to do some more of the coordination. It's kind of moving some of those tasks down. But so we're saying, no, they're not just helping physicians, they're helping NPs too, But it's a very interesting thing, and it seems like it's really taking on steam. So you're really right on top of something very important, I think, here.
Yeah, I'm also doing some work on community health centers, and I'll just take 1 second to describe this because it's really complementary to this. And we did using UDS data, which is the reporting data system for federally qualified community health centers. We did a maximum variety sample where we looked at clinics that had the most number of advanced practice providers, i.e. no doctors, the most number of RNs and LPNs, because you can't divide them in that data system, the most MAs, and the most enabling staff, which are community health workers and educators. And to see why they were staffed that way, how much of it was context driven and how much of it was sort of a purposeful management decision. And the centers that were high nurse, like 65% of the staff is nurse, were the only centers that kind of defended their models. The others sort of said, well, because we couldn't get physicians, or because that's who's here. But they tended to be, they aren't the classic nurse-led that are related to the School of Nursing kind of model that don't tend to use RNs very much at all. But these centers did, and they did in areas where commercial carriers were reimbursing, and no one has really looked at that model. It's a completely, outlier model, but it hasn't been documented as an innovation that might be cost effective. Well, the leaders of those centers believe that it's incredibly cost effective, in part because of the joy of alleviating the physician work, but also because it's just cost effective. The nurses are doing 80% of the work and perfectly capable of doing it. But it's really hard to evaluate that model. We've been thinking about how to do this. Some of you may know a researcher who's now at Duke, who's a PA, Chris Everett, who I think is sort of the first one, there may be others out there, so she's one of the first to be looking at sort of who's doing what in relation to outcomes. So she did a study of NPs and PAs. She had 3 iterations published in 3 different journals. But she was looking at, sort of observation of the distribution of tasks in relation to process measures in the EHR in relation to claims data. And that methodology, I think, is potentially what we should be thinking about to try to take a next step, sort of baby steps towards understanding the effectiveness of different models. And we need to look at how the sort of nurse-heavy model in primary care, RN or LPN, because what I hear from community health centers is they really value their LPNs because A, they're doing a lot of the same work. They're very different from MAs in that they have clinical training, and most of all because they can grow their own. So you have an LPN, they then go back and get their ADN, their BSN, their NP. You're with that person for decades, and they stay there. And so in these remote areas that have real recruitment issues, the grow your own nurse model is tremendously cost effective, as opposed to other kinds of professions that cycle in and out and leave right away. And I don't think the literature thus far has understood the importance or the potential importance of LPNs in primary care, and the importance of LPNs as a entryway to nursing in primary care. We just haven't conceptualized it that way, and it's a really, at least those community health centers that had the nurse-heavy models, they were talking about, there were no BSNs there. It was LPNs and ADNs that were leading the charge, because they were rural areas, and they are convinced that what they're doing is we talked to them about how they saw other models. The only other model that their leadership was really interested in was the issue of using a pharmacist for medication management with their older population, and they weren't sure if using a nurse versus a pharmacist would be more cost effective. They had no doubt about using a nurse versus an MA being more cost effective, and no doubt that they could diminish the number of providers they needed if they had more nurses, which is not a usual kind of calculation that you hear people talking about.
Have you looked at Kaiser Permanente and how because they use nurses quite extensively in primary care, and for a lot of different roles.
Yeah, it would be really interesting to do that. I have not. Yeah. I mean, I've heard Marilyn Chen is their chief nurse officer. She, in one of the IOM workshops that actually have been videotaped, and you can see she talked about, her dream was to have every patient should have a primary care nurse as the entry point to the system, instead of a primary care physician as the entry point.
Because they have also
And not an NP, an RN.
Right, an RN. Yeah, and they're very big on. In fact, sometimes I think more they use RN sometimes when they should really be using other, like nurse practitioners. But they really have a whole system of using nurses as sort of a precursor to seeing another type of provider. So that the patient could then see that line of provider first. Like, for example, if someone has a sore throat, they don't usually see the nurse, but they can go to the lab and get a throat culture, and then they can call the nurse later to find out what the result is, and she can call the prescription in. So it's like it really saves time for the patient and saves them for the health plan. So they really utilize nurses a lot. And the other piece about using the nurses within that system, and what I've also seen in other systems is, with MAs, the physician is the supervisor, and they're not always aware of all the quality issues that the nurses are. And so when you have nurses and that are supervising other nurses, you have more systems, and so then you have better quality effectiveness than in other systems.
Yeah. There's another study that our group has produced. Leighton Koo actually led this study where we looked at different staffing configurations in community health workers, in community health centers, excuse me. And the first level conclusion is you could have vastly different configurations and the productivity actually doesn't change that much. But the second level conclusion was, well, actually, if you have a whole lot of one type of professional, you see much higher productivity. And that was particularly the case with nurses. So, the centers that had higher ratios of nurses were not more productive. In fact, they were slightly less productive than those that had high ratios of physicians. But if you compare the numbers of nurses within a center to, say it was 20% versus 60%, you see enormous efficiencies being created, which I think speaks to, one doesn't know from the data, but it suggests that maybe there are systems being put in place that are completely different and new roles that are different. When you have critical mass, you can't have, if you just have one nurse and one MA and one NP and one pharmacist and one of everything, you can't really create a system of anything. And so there's rethinking of the delivery of care when you have higher volumes, which I guess speaks to the importance of, getting beyond these small, fragmented little practices.
Well, it also kind of speaks to what you're talking about in terms of the CNOs not having a comparative person in the primary care setting, because there's no system generally if it's a small setting. But if you have sort of similar system in place, then.
You know, what would be interesting to see is how many of them have nurses as their CEOs. Because that's sort of like having a CNO,
Yeah,
you know,
exactly.
that's thinking about the system issue. Yeah.
Polly, what year did you do those interviews? And I'm wondering if you are moving on to do a survey more broadly of ACOs to look at sort of how broadly it's changed among the much larger group of accountable care organizations.
So these were done in last year, 2013. And are we thinking about doing a survey? I hadn't thought about doing a survey. It's a good idea. We should talk about it. We have this. This may be of interest to some of you all as well. There's, Premier, which is essentially an association of hospitals and health systems, and they provide consulting services mostly on quality and patient safety, and they collect a boatload of data that nobody has access to and that is very useful. Well, it turns out they have a whole database on what they call their operational database, which is all workforce stuff. And although it's hospitals mostly, they're just starting with primary care state by state. They just started with North Carolina. But we've been talking to them about how we could partner with them to do some research, and there are a bunch of different things that we've talked about. One of the things is to look at staffing in ACOs versus non-ACOs and how it's changing. And we can actually do it longitudinally because they have data over time, and we can look at adoption as a time series kind of a way. So that would be restricted in the sense that it only looks at one slice of the ACO, but it could be interesting. I mean, I guess my sense of the survey is that the holy grail for me is always whether this is effective or not. And the question is whether a survey would get us closer to that. I guess it would help us firm up the typologies and get consensus around those typologies. That would be useful. Because I think, these may be the right typologies or they may not. I don't know. Our sample is so small, does it really resonate with others? But ultimately, I think we need to push it further and start looking at how this relates to outcomes in a systems level way and not an single intervention kind of a way. So the research to date has been, Mary Naylor's model, RCT, with or without. And that kind of a controlled experiment is really, really useful. But we also now have to see how that plays out in the context of a real health system that has a billion other things going on, and understanding what the trade-offs are if you go with that route versus this other route, and all that dirty stuff that's hard to deal with in research. And I think that's where, Chung Young, to some extent, you're looking at. This is going to be you're going to lead the way, and we're going to.
And actually, back to your study, I'm just curious that you just mostly kind of gathering how ACO use RN differently, or do you have like a big picture of how the staffing?
No,
The
I
whole
only,
study.
yeah,
Just
this is
get
the
it.
problem with research. You can only bite off so much. So
Maybe,
yeah.
in the future, it would be very interesting to know how these step compositions differ by their patient kind of characteristics.
Yeah.
And what's the most effective staffing models for
For specific patient populations, yeah.
populations? Maybe.
I mean, clearly they're using a lot more lay people in unlicensed assistive personnel, as they're called, in BLS data, to do a lot of the data management and some of the follow-up and education and blah, blah, blah. That seems to be pretty clear. It would be really interesting. I mean, obviously a big thing about ACOs is stratification, the segmentation of the population, and thinking about different configuration of teams for different types of patient groups would be a good descriptive study, yeah. I mean, anecdotally, I sort of heard that they tended to use more, advanced practice providers for the high-risk segmentations, and for the lower risk, they would use more, community health workers and that kind of.
That's what I heard from anecdotally.
Yeah. Well, I probably heard it anecdotally from you, so I have to be careful about the anecdotes.
Our conversation, yes. Some ACO is actually located in some rural community area. Most of their population are just chronic disease patients or not severe In that case, they hire a lot of community health workers than RN. But the pioneer, I think ACO in most cases, they're aiming at reducing the high kind of cost.
Yeah, I mean,
For the
what's
high
happened
risk.
in
That's
terms
why-
of looking at the
yeah.
outcome piece? I mean, because I think that's where the money shots are.
Right.
You know, in terms of readmissions, in terms of complications in certain populations like diabetes and stroke rates and things like that, if you start looking across different ACOs and different models, if they're measuring these particular indicators, what are they finding if the RN mix is this? What are they finding if they use a lower level of personnel to do that particular job function, or they don't have it at all? What happens there?
Yeah, but I think underneath that is what are people actually doing, like I was talking about this range from literally scribing, taking notes for the doctor when he's, instead of having them use keeping them from using the EMRs, to very high level work like coordination. So I think it'd be important to know what they're actually doing. You may find LPNs doing something but what is it they're actually doing versus what their title is, because it's all so vague.
Yeah.
To me, I think that'd be important at some level to find out.
So we talked about the doctors being happy. What about the patients? Are
The joy factor for
Yeah.
the patients.
Good question. I mean, I think, we've talked a little bit. I was telling Chung Young about this idea, talked a little bit with Chris, and I mentioned to you the idea that we could maybe use some of the patient engagement work that Jessica has done, this module that you have to pay through the nose for. Not actually that much. I looked up the prices. It's affordable. To see, so that's not really patient satisfaction, but it would be, compare different workforce configurations and actually see, what the engagement is as a result, which would be, a patient-reported outcome that is not as hard to get as, going through the Medicaid claims data for every single state or whatever. That if we could get them to adopt that as part of their EMR, then we could prospectively track that in different kinds of settings where they had different kinds of team models and see how that related. Has anything like that been done?
So I did a paper with this one pioneer ACO that basically found that primary care providers have a range of, their patients range in activation. There wasn't a lot of clustering of patients by activation level to certain providers. So we sort of know that providers get the range. But we're also starting to see that there are providers whose patients' PAM change over time is greater and lesser, and we've done some in-depth interviews with the providers who seem to be better at engaging their patients and listening, understanding their strategies, and they really are very different than the providers at the bottom of that spectrum whose patients aren't improving as much on activation.
So an expansion of that would be, well, we know that providers aren't the only ones who touch patients, so
Yes.
who else is there? And what do they look like, and how do those teams differ? As opposed to just the doctor-patient relationship. It should be more,
Providers are busy. They don't really have time to be calling back the patients, so that's where the RN comes in.
Yeah, lots of ideas for research for sure. I mean, I think, and then tying the patient activation module to the outcomes too, and seeing readmissions and even mortality and stuff like that. But the mushy part, and the reason nobody does work in this area, is the workforce configuration part, because we can't get our act together as a field to kind of describe distinct models. We haven't gotten there yet, and so it's really hard to know whether you're comparing apples to apples or what the differences are. So I think there is a place for more exploratory work on this and more consensus kind of work that I think the Academy could lead, just to sort of agree that these are the categories that we should be assessing. We don't even know what we're assessing. Because in the Elliott Fisher and Steve Shortell models of assessing ACOs, you go from context to outcomes, and just the black box of delivery system change is really mysterious. And the only workforce work that they've done is around physician buy-in to the ACO. And that's interesting, that's good. We don't want them to push back on ACOs the way they did on HMOs. That's really interesting. But what about what's actually gonna change? What is the mechanism? You're gonna incent them to change, and then they do. What's the mechanism? It's invisible. Yeah. So, trying to make that mechanism more visible, but it's sort of a slog because it's mushy and hard to, articulate. And as you said, that you have, okay, great, you have a ratio of nurses. It turns out nurses do vastly different things in different places, and so there are many layers of variability that are hard to get your head around. And it really is a program of research. I mean, maybe this is something where, our little workforce center, our future, hopefully, institute in the School of Nursing and the new MFA, ACO, and others could all collaborate for something that is sort of a longer program of research to try to establish what these categories are that we should be evaluating, so that we can understand what's in that black box and link it with real effectiveness research, not just efficacy research, to outcomes. Because otherwise the learning is slow.
Can you speak a little more? I was interested in your comment about this is my word, mismatch between what schools are training and what their needs are for population health. Can you talk a little bit more about the kinds of things specifically?
I mean,
or was
this
it
is
context
not going to be
depending
new
on-
to you. I think that this has been a lament for the last at least 10 or 15 years.
And it's in every health profession, really. It's just not nursing.
It is,
Yeah,
actually.
it's across the board.
That, nurses are trained for acute care settings, and we're trying to, we're developing roles outside of acute care settings. And so we, the ACO and the health system, have to figure out how to train them because they don't know how to do it. And we, the health system, are using the Geisinger training module and the Michigan training model, and we don't know which is better. And couldn't the education sector just figure this out for us and either train people before they graduate in tracks so that we don't have to hire a care coordinator that comes out of acute care. We hire a care coordinator that comes out of GW's care coordination program. Or could GW give us a training program that we could adopt as a system, and you've already gotten credentialed and figured out it's the best. They don't want to be in the business of doing this, and it costs a lot of money. They don't know what they're doing. I mean, it's bad enough on the staffing side, not knowing who to hire and what ratios, because the evidence isn't there either. But on the education side, they don't want to be spending all the time retraining people. It's really remarkable how much of that they have to do, and I guess they can't create economies of scale because they don't really collaborate with their competitors, and so there are some places that have been talking. There are some communities like Chicago that have really good fora where the educational institutions are meeting with the employers and talking about these things, and presumably those schools are moving forward. And at Salzburg in the School of Nursing is through an Academic Excellence Incentive Award that we got, and Jean is co-chairing this initiative to convene employers in this area to talk about this very issue, not just for nursing, but generally what they need from health professional education institutions, and how GW can do a better job of attending to those needs. I mean, one of the things that came out in our little planning meeting from some folks from a PA program is, well, GW is sort of unique because we have distance we don't train people that actually practice here. And if you're convening local employers, and what's the match, But, people are recruited from across the country, across the globe. I think the dialogue at any level is definitely a first step forward, even though it's not a perfect match.
Yeah. About half of our students, so 40%.
Yeah.
Most of it's actually.
It's spread.
You know,
Yeah,
it's actually.
Yeah,
the majority.
and, you know, mostly nurse practitioners.
It'd be interesting to see, we were talking today about whether we could, in addition to the GW ACO, what are the other ACOs that are local? And it'd be interesting to convene them as a group and understand their needs, and then convene the non-ACOs and understand their needs, and we have a little paper.
I was going to say, I think there's an ACO at Anne Arundel Medical Center in
Oh, is there?
Maryland. And I've worked as a nurse practitioner on the hospital side as an internal medicine hospitalist. And we had a whole group of nurses that worked as care coordinators, and also a large group of social workers that worked on those transition pieces. And they had an incredible, way of moving people through the system, which was at that point just beginning to move into that ACO model about 3 years ago, which is probably much more mature at this point. But they were also hiring physicians to look at the side in terms of efficiencies in when people should be leaving the hospital, or they shouldn't be in observation status, or they should be here or there, and that kind of thing. And they do across their system they use the EHR. It starts with an E, and I'm blanking on the name of it. Epic, yes. And interestingly enough, at the time that I was working for them, the outpatient Epic didn't speak to the inpatient Epic,
That's a real
which is a real problem. But hopefully some efficiencies have worked across there over time, because Epic was brand new pretty much in the time frame that I was there. But that might be an organization that would be worth investigating in terms of how their ACO has matured over time.
They're right in my neighborhood.
I've just noticed that we are out of time, so I'd like everybody to thank Polly.
Yes,
and-
thank you.
Thank you.